like to introduce Dr. Diana Wally, who is she is our neurologist for the Do15Q clinic here at Children's Colorado that was just open. So it's great to meet you in person. Hi. And then we have Dr. Demarest, who is the head of the clinic for for 8P and Ring 14 here at Children's Colorado. So welcome. And I'm going to let you guys introduce yourselves and just kind of talk about care, and then we'll go through the questions.
Hello, I'm Diana Wally. I am the co-director of the Chromosome 15 clinic. I'm an assistant professor at Children's here. And yeah, we opened up about a year ago and do a multidisciplinary clinic for all things related to chromosome 15.
Hi everyone, I'm Scott Demarest. I'm a pediatric neurologist and epileptologist, and I run the 8P Ring 14 clinic here that we had our first day yesterday, which is great. And nice to see all of you.
Can we have Dr. Thiebert and Dr. Jespe introduce themselves? I think they're in Zoom.
Hi, everyone. Sorry to not be able to be there in person. I'm Dr. Shapali Jespe. I'm a pediatric neurologist. I just moved. This is why I'm not at the meeting. I moved this week from UCLA to Children's Hospital LA, where I am chief of neurology, and we will be starting a 15Q clinic. Can you hear me?
Yes, we can hear you.
We'll be starting a 15Q clinic at CHLA in the fall. I ran the 15Q clinic at UCLA. I hear background, sorry. There's some echoing. Anyway, but nice to remotely meet all of you and hope to meet you all in person if you choose to come to LA.
Oh, hi, I'm Ron Thiebert. I'm another pediatric neurologist, epileptologist at Mass General in Boston. And we opened our Do15 clinic in 2010. So I guess it's been about 11 years now. We've seen probably over 150 families already. So I'm also sorry I can't be there. I love these meetings, but I just couldn't make it out this year.
And our first question is talking about medications. So when you go into your neurologist or when you're approaching that conversation, what's the best way to really open up that conversation about medication options, or when you want to change medications? So what's the best way to go about that, especially when you're dealing with AEDs? Who wants to go first? Well, let Diana go first.
Is this one? Okay, great. I think, you guys are the #1 advocates for your child. Most epilepsy docs like myself and Dr. Demarest are quite open to medication changes. Our goals are always no seizures, no side effects. That isn't always a possibility, but that is always our goal. And so I think just approaching saying this isn't working for us, or this is working for us, but not quite enough. What other options are there? I don't think anybody would be upset and or insulted if you said, this is really a side effect. And even if it's not something that we've seen, doesn't mean it doesn't exist, right? And so just really being an advocate and saying it's not working, what else can we do, I think is really important.
As a follow-up to that, another question that came in was, the request for neurologists to present was, what recommendations do you make for Do15Q? What medications work? Or what medications work for 8P? Or what medications are recommended for Ring 14? And I actually asked Scott this, and he's like, so.
Yeah, so maybe I'll speak to my new experience with 8P and Ring 14, which is to say that there's not specific medications that are shown to be better for either of those conditions than other seizure meds. Unfortunately, we're still in a stage of significant trial and error with every individual patient at this point with epilepsy. other than some rare circumstances. I think one of the reasons to have a clinic or clinics like we do is that we learn from that, and we can start to figure this out over time. Are there certain medicines that tend to work better or not? But at least for Ring 14 and 8P, there's not anything that's really standing out so far. So a lot of times you're trying to pick based on what are the side effects and what are the types of seizures you have, and make some rational decisions around that to see what works for that child.
Ron or
I'll let
Chevelle?
others speak towards.
I was going to say,
Duke
Dr.
15.
Thiebert or Dr. Jeste, do you want to talk about Duke 15Q and your experience with medications?
Oh, sure. I can take that one. Yeah. One of the things that kind of to me stands out with Duke 15, unfortunately, is that there isn't really one or two medicines that work better than the others. With other syndromes, like for Angelman, for example, there's a few medicines that really work well that we can kind of stick with. For Duke 15, it's been one of those things where, we'll put someone on a medicine that really hasn't responded much well to anything, and they do great on whatever, go from 25 seizures a day to a couple a week on, either Banzel or Fycompa or Vimpat. And then, we put like 2 or 3 more kids on it because it works so well. We think it's the magic drug, and then it doesn't work as well. But so I think kind of the bad news is that there really aren't drugs that seem to work in Duke 15 better than others. But then the good news is that, we have seen kids respond really well to several different drugs. So it's just one of those syndromes where it seems like it's very person specific, and each kid seems to have their drug, and it's just a matter of finding the right one. And like it was already said, you try to make the best choice based on like how the drug works and the potential side effects, and then often you have to kind of keep cycling through until you find that right combination. But luckily we often do find the right combination. It just unfortunately there is some trial and error involved. So but yeah, over the years we've thought that several different drugs might be the drug, and they don't work for everybody, but we have been able to match kids up with their right drug most of the time. And often it's a combination. It's pretty rare for the kids that have the Lennox-Gastaut type of Duke 15 seizures. It's rarely just one drug, so it's finding that combination of medicines that work but don't have excessive side effects.
So just to jump in and answer.
And then can you also talk about duration too? How long should they be on these meds once they're on them? Is multiple people are asking that question.
I mean, I would just say it's, go ahead.
Oh, no, I was going to say, go ahead. Yeah.
No, I mean, I think just sort of piggybacking on what everyone already said, I think it's very hard to generalize that answer because it really depends on how the child's doing on the medications that are, prescribed. And I just want to make one other point about the sort of first question you asked, Vanessa, about what can parents sort of do. And I agree that parents are their child's, but not just biggest advocate, but best historian. So they know exactly what the experience is with every medication. I have like a table that I create that I put in all my clinic notes that if parents can sort of come with that information, it helps a lot for continuity of care, especially if parents are seeing multiple providers and specialists, which is a table that has the meds that they've been on, the highest dose they took, the duration, and why it was stopped. And that really helps because sometimes, and I do treat epilepsy, but I tend to spend much more of my time managing medications for behavioral issues, psychiatric comorbidities, those sorts of things. And I'll often see kiddos who have, parents will report that they've been on many, many medications in the past. And sometimes it's that someone tried something for a short period of time. It's not really clear if it worked or not, so it was taken off. But that's a very different, scenario than if a medication was used and had a horrible side effect, or interacted poorly with one of the anti-epileptics, and so they stopped it for that reason. So as specialists, if we can sort of really understand what the med history is, it really helps us make decisions on future medications.
So I think this one, how aggressively would you try to treat ES?
Yes.
How
Just kidding.
aggressively?
No, yes, I was trying to be funny. So it didn't work. I think it depends. I think ESCS is a wonderful topic that we could have our own conference on. And I think we are, as epilepsy providers, still trying to figure out how hard we push to treat it, and even what we use to treat it. And so I think if we saw some of the sort of major criteria being met of regression or stasis of milestones, regression or stasis of behavior, that we probably would try pretty aggressively, with the caveat that, you know, we use a med, it gets better, we take it off, and it's again, not great. Trying a couple of different things. But in the end, I think if we're not seeing any type of regression or stasis of any type of milestones, that we probably would not push super hard to treat, because it's going to be, we're just going to end up giving child lots and lots of side effects from some of the meds that we use.
Yeah, I totally agree. Ultimately, ESES is like many things in treating epilepsy, particularly epilepsy that's challenging to treat. It's all about a balance. You're trying to balance the potential side effects or real side effects of the medications with improving quality of life, seizure control. In this case, the target behaviors, how well you're functioning for ESES. And so if you're not getting much benefit and you're getting a lot of side effects, then you're probably on the wrong path. And you might try several things, but at the end of the day, if the drugs are worse than the questionable effect of the ESES, then you have to think about that.
This is a great question. What's your approach for EEGs and sleep studies in kids like this, before or after seizure onset? So EEGs, regular routine EEGs, sleep studies, how do you usually approach that? Why don't we go with Shapali on this one first?
So if you mean, you know, when should we be getting EEGs, I can answer that quickly, but then in terms of approach, like how do you help prep a child or a family for an actual EEG, because that can be difficult for some kids. That's another sort of set of questions that are, but in terms of EEG, so I'll talk about DUP15Q specifically, which is that we know that especially with kids with IDIC 15, the rate of epilepsy is very high, more than 50%. And we do know that sometimes kids can have, you know, spikes and even maybe subclinical seizures before, you know, we see more clear clinical seizures. So we, as a group, we didn't write this out as a guideline, and Ron was a part of this, but a few years ago, just based on the understood prevalence of epilepsy, we sort of agreed that we would, on any child who was newly diagnosed with IDIC 15, that we would actually get a baseline overnight EEG to have a baseline, not necessarily treating spikes at that time. And that's sort of gets into the question before, but just that we would have a baseline. And then after that, based on, you know, how a child's doing clinically, we'll obtain EEGs. If there's new spells that we want to capture, if most of the seizures that we've identified are not clinical, meaning we don't have a behavioral correlate, then we might get more EEGs down the road to see if the medication is actually working. So those decisions on the EEGs are really on a case-by-case basis based on how we're monitoring the seizures. But in DUP15Q, we are pretty routinely getting overnight EEGs. It depends on the place where you are, honestly. About like at UCLA, it was easier to admit a child for an overnight EEG. And I actually think the data quality were better, because if a lead got pulled off or something happened at night, there was a team there who could, you know, replace the leads and make sure that the EEG data were good enough that we could actually interpret it. I'm less of a fan of the home overnight EEGs, because I think sometimes the quality is just not as good. And I think probably I see you guys shaking your heads or nodding in agreement, but it is sometimes easier to do it at home. I understand that. So anyway, I'll stop there, but I'm sure others can jump in.
So I guess I would jump on that for sleep studies, since that was the second part of the question. I'm not a sleep doctor. I don't read sleep studies, but they are an important tool. I think particularly when you're trying to figure out if there are sleep challenges, are those sleep challenges due to things that are happening in the brain? That could be seizures, that could be just dysregulated sleep patterns for various reasons, which happens a lot in various neurogenetic conditions. Or is it because there's something airway related, like an obstructive sleep apnea process that's happening? There is some risk for that in 8P oftentimes. And I think you need to try to piece those apart. So you would order a sleep study, and in some cases, it's actually nice if an institution can do it to be able to do a sleep study combined with an EEG. A regular sleep study doesn't have a full EEG, but if you can do them combined, then you can kind of say, okay, well, what caused that event? What caused that event? Was that an obstructive event? Was that a central process or a seizure that happened? And you can piece through those. Again, in most cases, I wouldn't necessarily just routinely do a sleep study for everyone, but I would do it based on some clinical concern being raised of disruption of sleep, daytime sleepiness, snoring. That seems, more than just sort of like basic snoring. And those would all be reasons to get a sleep study, and possibly, depending on the situation, try to combine it with an EEG.
Follow-up question to the EEG assessments. How hard do you push to capture a seizure on EEG versus treating what the parent is saying? As an anecdote, the EEG is the best AED they've ever tried. So hooking them up makes the seizure stop.
That is always the
They're
case.
monitoring
Also, when I make a sound for my car and I bring it into the auto mechanic and he's like, there's nothing wrong with your car. And I was like, all the way here, it was making this silly noise. So I think from an epilepsy standpoint, whether or not to capture spells, I think if you are able to video it, that is really, really, really helpful for a neurologist to sort of say, that could be a seizure, or it's probably not, especially if we can't capture it. Again, we don't want to keep anybody inpatient for 2 weeks to capture a spell. That's not a thing. We don't want to increase the medical trauma that these kids already go through on a regular basis. And so, again, it's sort of, if we can see it, or if it can be really well described, that's really helpful. If we can capture it, great. We'll try very hard to capture it, but again, we're not going to keep you in for 2 weeks. And so some of it may be, here, we didn't capture it. It sounds like a seizure. Let's try and treat it. And if nothing changes with our interventions, the chance of this being seizure starts to decrease.
In follow-up to that, Dr. Thiebert, can you speak a little bit to the behaviors or the jerks that you have done some research on that aren't seizures, but they look a lot like it? Can you talk a little bit about that and how to approach that?
Oh, sure. Yeah. Sometimes people have what we call myoclonus, which is kind of a quick jerk. It's often of the kind of the extremities, but it can be, it can also be like if you're, listening to this lecture and falling asleep and, you kind of jerk back up, that's kind of a myoclonic jerk. So myoclonus can be totally normal, like what we call sleep myoclonus. So, when we sleep, we all twitch a little bit. You kind of have that dream like you're falling and you twitch yourself awake. That's myoclonus. You can have myoclonic seizures, which are usually, which are more common in younger kids, where there's more intense kind of twitching, and it's while awake during the day, and we'll actually see a change on the EEG when that happens. But then there's also another thing we call non-epileptic myoclonus, where you get that kind of twitching or jerking, and if you had an EEG on at that time, you wouldn't see anything on the EEG. And so it's neurologic, and it's often related to genetic syndromes, but it's not technically seizures. So at that point, it becomes more of a quality of life issue. In kids at DUP15, we've mainly seen just single jerks here and there, or maybe a couple in a row. So not sustained, but we know in our older patients, older meaning like teens and adults with Angelman syndrome, they can have sustained twitching for minutes, for hours, even for some people. And the people are totally awake and alert while it's happening. The EEG doesn't show anything. But so if there's myoclonus and it's not epileptic, the decision to treat is really based on quality of life. If it's just the occasional jerk here and there, it doesn't bother them. We just kind of just let it be. It's more part of the movement disorder than epilepsy. But if it's frequent enough to the point where it's getting in the way of eating or other kind of motor skills that are important, or if it's in kind of more rare circumstances, if it's impressive enough that it can even cause people to fall if they're standing, that's when we want to treat it more aggressively, really just for safety and quality of life reasons. But yeah, the myoclonus is tricky because it's not, sometimes it's totally normal, sometimes it's not normal but not seizure, and then sometimes it's seizure related. So if it's happening frequently enough, even just a regular EEG, you probably catch a couple of jerks and you'll know. Other things are if people are totally awake and alert and don't have any change in what they're thinking or doing or acting, it's more often non-epileptic, but it's not as common in DUP15 as some other syndromes, but we do see it. And then it's, we just basically, if it's not seizure, we treat it based on whether it's causing, either safety issues or if it's just bothersome enough during daily life that we think that, and the families are usually the ones to know best. If it really seems to be bothering the people that have it, then we treat it more aggressively.
Great. Can you talk about the types of seizures that you see in these syndromes? So DUP15Q, 8P, ring 14. We heard LGS. What is LGS? And the types of seizures that we see in these populations.
I can start with the DUP15 kids. When we think about seizures in DUP15, we think about them as being focal or multifocal, meaning they come from one part of the brain or from multiple different parts of the brain. So when they come from one part of the brain and they kind of stay there, we call that a focal seizure, and that may show up. Sometimes it's only just staring. Sometimes it's staring but with eyes deviated, or you can see some movements or change in posture with like one arm, or the head might turn. And those are the easier ones to treat in DUP15. And for those kind of seizures, pretty much any of the seizure meds are able to treat that. The ones that are more broad and treat lots of types, or the ones that really just kind of treat focal seizures. When all those different kind of areas that might cause seizures kind of start doing that at the same time, then you can see on the EEG kind of seizures that are kind of coming from the whole brain. It looks like on EEG. So that's what we call secondarily generalized. And you can get something called Lennox-Gastaut syndrome. LGS is the kind of the short way of saying it. And it's with LGS, there's a certain kind of EEG characteristic that we typically see. There's, it's in kids that have developmental issues. And then it's multiple different seizure types. And the main ones are, you can get what we call tonic-clonics. Those are what some people call grand mal, the big, everything shaking, eyes roll back kind of seizures. You can get what we call atonic seizures, where those are kind of thought of as drop seizures. So either it's a quick head drop, or sometimes it's the whole body. You can just kind of drop down and fall to the ground, or if in a chair, kind of slump over. And then another one is tonic. So that's stiffening. And that will usually last for a few seconds. Another one is atypical absence, which sometimes it's hard to differentiate from a focal seizure. It's, staring, but for longer periods, not just a few seconds, but for, 10, 20, 30 seconds, sometimes more. And people usually aren't totally unconscious when that happens. They're usually just kind of altered. They're not quite themselves, but they're not completely unresponsive. And then, so those are the big ones. And you typically get multiple seizure types. So you'll have, 2 or more of those with the generalized abnormal EEG and also the developmental delays, and that kind of qualifies as Lennox-Gastaut. The one wrinkle for DUP15 that's a little bit different from some other syndromes is that along with those kind of typical Lennox-Gastaut seizure types, you can also have spasms. So we all think of infantile spasms, kids under a year that have these kind of episodes where like the head and the arms will kind of flex forward or kind of extend backwards. They tend to happen in clusters. most often, those kind of will eventually resolve, and then they can transition into this Lennox-Gastaut type epilepsy. But in kids with DUP15, you can have the spasms later in life as well. So for whatever reason, the most common age for Lennox-Gastaut in general is usually kind of 2, 3, 4, that neighborhood. But in kids with DUP15, we often see it more like 7, 8, 9. So it's a little bit of a later onset, kind of in that pre-puberty era. So oftentimes kids will have spasms, then will go away, or they just don't have any seizures for a while. And then when they get a little bit older, 7, 8, 9 is often a kind of typical time we'll see, we'll see these seizures kind of start up again. The focal seizures can start at any point. And one of the most common times to see the focal seizures kind of kick up if things have been going well is around puberty. Those are kind of that kind of infancy period. And then with the Lennox-Gastaut type seizures, they can occur at the usual time, like 2, 3, or 4, but more often really in DUP15, it's more like 7, 8, or 9, which is really kind of a unique DUP15 thing. And then the focal seizures typically either kind of in the early school years or in adolescence. And then the other thing with DUP15 that's really important to remember is that about 40 to 50% of kids just don't have seizures, which is great. So it's one of those things where, there's really a lot of variability. Some kids will just never have them, and that's ideal. And then some will, and out of the ones that do, sometimes they're just focal seizures that are pretty easy to treat, and then sometimes they're this really difficult Lennox-Gastaut type of epilepsy. And looking at the genetic reports, there's really no way to know. Every kid's a little bit different the way the syndrome presents.
Great. So kind of pivoting a little bit before we get to you guys, I'm going to come back to you, but I want to pivot a little bit on this. A great question was asked: outside of epilepsy, outside of seizures, what other neurodevelopmental things are occurring in these populations? I'll let Shapali go first, and then I want you guys to hit on AP and ring 14 seizure types and other neurodevelopmental disorders.
So, and this actually applies probably across most genetic conditions, which is that, development is usually affected in some way, but there's a huge range. And in DUP15Q in particular, which again, I have the most experience in, some of you who might be in this audience have been a part of our studies that we've been able to do at the family meetings. I know there's work being done again at this meeting, which is super exciting. We have found that, some level of developmental delay was evident in most kids actually with DUP15Q, but again, huge range in which areas were most affected, meaning, when we look at development, we evaluate language skills, motor skills, social skills, daily living skills, which are also often affected by those other areas, cognition, learning, those sorts of things. Specific diagnoses, neurodevelopmental diagnoses. So the two most common ones we'll make early in childhood are global developmental delay, which means that there's delays in at least 2 areas, and that's usually motor and language. Motor skills are particularly affected in DUP15Q because a lot of kiddos have low tone, which can affect the timing of when they start, reaching milestones like sitting up and walking and those sorts of things. So global delay is one. And then the other diagnosis that we're making, I wouldn't say commonly, but more often is autism spectrum disorder. That's a diagnosis that, again, I'm very careful about not making until a child's old enough and has the developmental level of which we can actually evaluate for autism. So there's a lot of measures that we do and tests that we do to look for autism. But if a child's really delayed or young and they're not at the point where they should be showing certain social skills or able to, participate in some of the activities, then we're not going to actually do that evaluation. So oftentimes what we're seeing is global developmental delay might be kind of the first diagnosis, and then later on a child might meet criteria for autism. But really the big picture point, and this is what I say to parents all the time, is that for me, these diagnoses, they definitely can help with accessing services. And so I think it's important for us as clinicians to be accurate when we make those, for sure. But in general, any child with a genetic condition, I think, needs very close developmental monitoring and interventions from an early age. My goal is that we are able to get our early intervention programs to buy into that, even if we're not giving a formal diagnosis of global delay or autism and those sorts of things, because we know that development is so important. and that any kind of surveillance and intervention can be very helpful for these kids, and can help families, know what to look for and what to kind of support at home. So I'm pretty aggressive about writing letters or whatever needs to happen to help make sure that interventions are put in place for a child even before they enter the school system at 3. So, yeah, so anyway, and I know there's some testing being done at this meeting. I just want to say thank you to all the families. I mean, we learned so much about Duke 15Q and just neurodevelopmental issues that these kids have. We learned because of the fact that we were able to work with families at the family meetings. We never would have been able to see enough kids if we required all of you to come to UCLA or wherever else to get tested. And so, having the parents engaged and the alliance engaged at the family meetings was really invaluable.
So I would jump off that to say that I think that there's a number of neurologic features that can happen across a whole range of neurogenetic conditions that we need to be aware of. And they may or may not be present in any one individual, but there's a higher risk for them, probably in all 3 disorders. And those would be things like sleep disturbances, which we touched on a little bit already. You can get behavior challenges that ties in a little bit to autism and the developmental delay and things like that. But in some cases can be really severe and need specific management. You can have other movements that aren't seizures that are abnormal that can occur. So there's really a whole host. There's probably some risk of having vision challenges actually as well. That aren't necessarily related to the eye, though in some conditions they may be. But even if the eye is fine, the brain may not be processing vid signals properly. And that's something known as cortical visual impairment. And that's something that I think we need to be screening for because we probably underdiagnose in a lot of neurogenetic conditions. So there's a whole host of things. I think when it comes down to it, if you have a gene that's abnormal in every cell in the brain, then you have the potential for dysfunction in all types of brain function. And so you need to be watching for all types of potential dysfunction in the brain with these conditions. And certain conditions may have a higher likelihood that you have a certain issue, sleep, for example, and other ones may not have as high an issue, but we should be watching for it across the board because we still see it in some kids, I think, in most of these conditions.
There are questions about MRIs. So we talked a little bit about epilepsy and other neurodevelopmental disorders, but structural changes that we're seeing in 8P, Ring 14, and Duke 15Q. Can you speak a little bit about the structural changes that we see and the potential interventions that you would need an MRI for, or that you'd want an MRI to be ordered for? So when is an EEG not enough, essentially?
So I'll start a little bit on that. So anyone with epilepsy needs an MRI, and that's regardless of neurogenetic condition, and probably rings true for most of your experiences. If you had seizures early in the course, you may not have even had a genetic diagnosis yet, and you got an MRI. So that's sort of a basic thing, and that's because we're looking for potential causes of seizures based on the structural development of the brain or whether there could be any prior injury or things like that. 8P has some specific changes that we're starting to see, mostly related to the corpus callosum, which is this big band of fibers that are connecting one hemisphere of the brain to the other hemisphere so that they can communicate to each other. And that can have be underdeveloped or absent in 8P kiddos. There can also be a few other subtle things, some changes in the cerebellum as well. And most of those actually don't tend to relate to epilepsy really strongly. There was another question about what's abnormal gray matter. So gray matter is the cortex, that's the outside of the brain. That's like the CPU, that's the thinking part of the brain. The white matter is the bundles of fibers that connect one part of the brain to another part to allow coordination of thought and movement and all of those sorts of things. So epilepsy tends to be derived from the cortex. It tends to come from the outside of the brain. But we see abnormalities, for example, with 8P in that bundle of fibers. That's white matter, right? So that's not part of the cortex, and may have some increased risk for seizures, but it's not the kind of things we see where we're like, oh, that's definitely going to cause a seizure. So I think there's still a lot to learn about exactly what types of variations there are in the brain for a number of these disorders. And I'd love somebody else to chat about DUP15 and whether there's anything to add on that front.
Oh, sure. I can take the DUP15 piece. The kind of, in the literature, when we first started seeing kids, the one thing that was described was also the corpus callosum, just some abnormalities with that, either kind of too thin or oddly shaped. But what we started seeing in the first group of kids that we were seeing in clinic was that there were also some abnormalities in what we call hippocampus. It's a structure that's kind of deeper inside the temporal lobes on either side, and not so much that they, sometimes if that is small or bright or just kind of abnormal looking on the MRI, it's it meant that there was some damage there, and it's now you're getting seizures from that neighborhood. But in this case, they were just either formed differently or kind of rotated differently. So really something that kind of happened as the brain was developing, and while that really seems to be kind of a signature for a lot of kids that do 15, those kids didn't necessarily have worse seizures than the kids that didn't have that. So it's more almost like of a marker of the disease versus something that's going to lead to issues. But the one thing that we do see sometimes, although not super common, is what we call cortical dysplasia or even heterotopia. So dysplasia is when the cortex, the gray matter, it just didn't quite form right as the brain was developing, or heterotopia is when the gray matter is inside the white matter where it's not supposed to be. And sometimes we'll see that on MRI, but there was a study looking at the pathology of the brain. So just basically taking samples of brain, looking under a microscope several years back, where there were just lots of little tiny dysplasias in the brain that really aren't big enough to see an MRI, but they're there. And that kind of dysplastic brain, just basically the cortex that just didn't form right in certain spots. That's the most common cause of infantile spasms or epileptic spasms. So that really helps explain why we see spasms in DUP15. Very similar, although not the same, but kind of the same concept as what we see in tuberous sclerosis, where there's dysplastic areas throughout the brain that cause seizures. So if you see a dysplasia on the MRI, when those little abnormal areas, then the odds of having seizures and having tough to control seizures goes up. But even if we don't see it on MRI, we just kind of know that they're there. If we were to look under a microscope, we'd see those little areas. But as far as what we kind of commonly see, it's the thinning of the corpus callosum, the kind of the rotation, kind of abnormally shaped hippocampi. And again, those don't necessarily correlate with the bigger seizure risk. They're just kind of part of the syndrome. But if we see other changes like dysplasias that we know are there, but if they're big enough to show up on an MRI, then that just it helps with kind of thinking about the future, just knowing that there's a lot higher risk of a seizure if there's a bigger area.
All right, we're getting questions back to intervention and treatments. So one was around a little bit of the attention deficit disorder that we see in some of these kids. So how would you go about treating attention deficit disorder? Excuse me. And the other one is around VNS or surgical interventions. So that's the two questions that are about us right now. Sorry.
I mean, yeah, I can jump in on the ADHD piece, and it's tough because, attentional challenges we see, I would say, I see in almost every patient that I take care of, especially if there's some developmental delays or challenges. And, then you add the effect of medications and other things. So, when does that become, formally diagnosed as ADHD? And, that's a diagnosis that we make based on interviewing parents and doing some assessments that look at basically how a child's able to pay attention. It has to be in two locations, really, like two domains, so home and school. So we want teacher reports to find out, are they having challenges paying attention at school? That's for pure attention issues. Some kids also have the hyperactivity and impulsivity, which are the other two parts of ADHD, if they have the full combined type. And again, we get information about the hyperactivity and impulsivity, both at school and home. And my approach generally is that if a child meets criteria for ADHD and which means that any of those issues, impulsivity, hyperactivity, inattention, are really getting in the way of their functioning. They're making it hard for them to be as successful as they could be in school, or they're unsafe at home because they're super impulsive and doing things that might be dangerous, or so inattentive they can't sit and have a meal with the family, or whatever the goals might be. If it's really getting in the way, then we will. I will talk with the family about medications. There have not been good clinical trials for ADHD in every genetic syndrome that we treat. So the question becomes, do we use the medications that we know work for, sort of the broader ADHD spectrum? And the answer is that's yes. The one caveat I would say is that I think in general, kids with genetic syndromes, especially, if they have epilepsy, and especially if they're taking other medications, they tend to be more sensitive to medication. So I'm just much more ginger about the dosing. We start very low and slow and monitor symptoms and side effects very closely. But we don't have I'll just put it this way, we have no data that tells us that any one medication is not effective or not safe. We get a lot of questions about stimulants and their effect on epilepsy. There have been studies on that, and there have not been robust sort of findings that say that stimulants definitely make epilepsy worse. But having said that, there are some clinicians, and I'm curious what the people on this panel, how they handle it, if a child has very severe seizures, might steer away from the stimulants. I tend to still use them if inattention is the main issue. There's other medications that are not stimulants, like alpha agonists. Some of you may have heard of those, like guanfacine or clonidine, that are, well tolerated and safe, but they're more effective for kind of the hyperactivity, impulsivity part of ADHD, because they tend to be calming. They tend to be so calming that we use them for sleep issues, right? Because they can cause sleepiness. But we can gingerly use a variety of different medications to treat symptoms. So there's no reason that we can't do it. We just have to be careful and really monitor closely.
So I think surgery and VNS. So I think when we sort of exhaust our medication, 2 or more that are medications that are failed, not for side effects, but at sort of their maximum doses, I think we then think about what is the next step. And from a surgical standpoint, I think it also goes to what we use the MRI for. If there is something abnormal in one of the hippocampi, or if there's a cortical dysplasia on the MRI, that makes epilepsy docs pretty happy, because we're like, ooh, we could take that out. And so if there is something like that, and somebody has failed multiple medications, I think we sort of go down that journey of surgical workup, meaning capturing seizures as an inpatient, then possibly doing more further testing from whether it's a PET scan, whether it's a MEG, and so sort of going down that journey. If there is nothing sort of focal that we can go after, then we sort of think about the other surgical interventions, meaning vagal nerve stimulator. And using that not just, but that with the caveat that that is not meant to be curative. It can reduce the seizures by about 50 to 60%, and it may significantly help reduce the amount of rescue medication that you have to give, because the magnet that we use can sometimes, when we ask that you use it when a kiddo is having a seizure, to swipe and see if we can abort the seizure that way. The other sort of surgical intervention, if there is nothing that we can see sort of either visually or on other sort of neuroimaging is we talk about a corpus callosotomy, and that's that sort of bundle of fibers that Dr. Demarest was talking about, and talking about would it be helpful in the particular type of epilepsy to split the corpus callosotomy. Again, we do not take any type of seizure surgery lightly, and so there has to be a lot of discussion and a lot of criteria met before, you know, we are willing to consider moving forward with it. Most institutions have sort of a seizure surgery team that somebody presents, the epilepsy doc presents their patient, and everybody in the room has to agree to move forward. And I'm not sure if you've ever met epilepsy docs, but it, you know, 12 docs, 13 opinions. So we really have to strongly feel that this is a good idea to move forward before we would consider that sort of next step intervention. And so, but I will say I have had a fair amount of success, certainly with at least decreasing the amount of rescue meds and the actual seizure burden. But I personally have not had anybody be seizure free with a vagal nerve stimulator.
So there's a lot of questions coming in about CVI. First, what is CVI? And two, and mostly how is it diagnosed? Who can diagnose it, and then treatment options?
Good questions. So CVI, the C can stand for two different things. The Europeans say cerebral, the North Americans say cortical, but either way, brain visual impairment is what you can think of it. So cortical visual impairment. Essentially what that is it means that there's nothing wrong with the actual eyeball itself. Light is coming in, it's hitting the retina is sending signals back to the brain. The brain has a really complicated process of trying to interpret and make sense of those signals. And we have a fairly large amount of our brain actually dedicated to that task through both that initial input and then areas around that try to make sense of complicated movements, colors, shapes, all kinds of things. And essentially cortical visual impairment is that the signals get back to the brain fine, but the brain has a hard time with interpreting that, making sense of it, putting it all together in a way that's meaningful to that individual. One thing that's really important to understand about cortical visual impairment that is different than blindness or an eye abnormality is this can be a whole range. So you can have a relatively mild cortical visual impairment where you maybe only have challenges with certain things, seeing contrast between two dark shapes or two light shapes. You need a higher contrast level, or maybe you have difficulty with certain colors or in certain areas of your visual field, but not all areas of your visual field. It can also be quite severe, where it's almost the same thing as blindness, and there's very little visual signals that can be processed. So there's a whole range of severity. It can also fluctuate over time, depending on how that individual is doing, what else is going on, how tired are they. They may struggle a little bit more with their vision some days than they do on other days. Like most things neurologic that tend to fluctuate. So that's sort of a description of what CVI is. Why does it matter? It matters because it needs to be integrated into therapies. That's the biggest thing. So there's not something that actually improves the way our brain processes vision. We don't have vision therapy. There is vision therapy out there, and you need to be careful. Some of it's good, some of it's sort of like, what are we doing? But if you are interacting with a child trying to get them to learn a particular task, and you're presenting them with an object that has low contrast or is not particularly colorful, that their brain is not processing well, they are unlikely to be successful in interacting with it. And so that sort of integration and awareness of it in terms of the other therapies that an individual is getting, PTOT, speech therapy, if you're using an assistive communication device, are you making the options that you're choosing large enough that you can actually see them and identify them and select them? So there's ripple effects that way into other therapies. That is the main reason to be aware of this and make that diagnosis. Who makes that diagnosis? a lot of people can make that diagnosis. It's a better question who's willing to make that diagnosis. Ophthalmologists tend to go, well, the eye looks fine, so you're okay. And then neurologists tend to be like, well, I don't know whether your eye's fine, so I'm not going to make that diagnosis. And everybody kind of wants to go like, not me, not me. It's a problem. I'm just being honest. So I think that a neurologist should be perfectly comfortable making a diagnosis of cortical visual impairment. And I think it's important to be aware of it and monitor for it. You may ask that a individual see an ophthalmologist if they've never seen an ophthalmologist, because we want to make sure there's not actually an eye reason for the explain why there might be challenges with vision. It can also be both, by the way. You can have an eye problem and a brain problem, right? So I think it takes a little bit of a team effort there, but I think we need to raise awareness about cortical visual impairment and neurogenetic conditions across the board, and try to make sure that we're identifying it appropriately.
Great. So we have 9 minutes left, and I think the last question that we're going to dig into is a tough one. How many medications is too many? And how do you work with a doctor who's just not listening to your concerns, your views about the medications that are being brought forward?
Okay. So, I think, again, everything is going to have to be individualized. I have patients on no medications. I have patients on 4 medications. My comfort level does not tend to be above 4 medications. It does not mean that I don't have a couple of kids on more than 4 medications. When we get to the multiple medications, as parents know way better than epilepsy docs, is the side effects, and what is the balance between too many seizures and too much medication. I think if somebody is not listening, that maybe try your best to have a conversation, and if that conversation is not going in the direction that you would like it, that maybe you need to talk to somebody else. We don't want your kids completely zonked out, but we also don't want to have continuous seizures all day, every day. And so I think that has to be a group decision, with the parents sort of leading those decisions on the balance of how much is too much, and if they are super tired all the time and there's no quality of life, then that's probably not the right combination. I think focusing a huge amount on quality of life is the most important thing. And if there are too many medications, then we probably need to consider other things like the diet, keto diet, modified Atkins diet, low glycemic index diet, to see if we can pull back some of those meds, and or talking about other interventions like VNS or other surgical interventions. And so again, this needs to be a partnership with your neurologist, epilepsy doctor. And if that is not being a constant conversation, then that might not be the best fit.
You deserve to be listened to, period. If you're not being listened to, find someone who will. I have a little bit different take than the 4 meds. I tend to aim for 2 meds. Doesn't mean I don't have anyone on 4 meds. Part of the reason for that is because sometimes you have to add a 3rd med before you take another one away. And so you might have sort of a transient period or more than that. It doesn't always work. The big thing is that the more meds you're on, the more side effects you're likely to have. And if you're not getting more seizure control and you're getting more side effects, then you're on too many meds. So the times when I am finding a patient that I am keeping on more meds, it's because when each of the meds is really helping something, right? So just sitting on a bunch of meds, not knowing what they're doing, is probably not the best strategy. But if you know, oh, we took this one away and this type of seizure got worse, we put it back on and it got better. Okay, well, I can't get rid of that one. All right, so what about another? And I've had that situation where I've had kids on 3 meds and each one of them is really doing something that is benefiting them and they're tolerating it. So if they're tolerating it pretty well, then it's okay to be on more meds. If you're not tolerating it and there's side effects, it's not okay. And less is better than more. And I'll just make one more sort of editorial here. Do one thing at a time when you're making med changes. If you make a bunch of med changes at the same time, you have no idea what's doing what and what's helping and what's hurting. Just make one change at a time and be a little bit patient about it, which I know I'm saying when you're like, no, my kid's seizing, like I'm not, are you kidding me? You can get into an oversteering sort of situation where you're making a change really quick and then, you know, things get better, but then you get side effects and then we got to pull away to get rid of the side effects. And then seizures get worse again. And you're kind of oscillating between them. The brain takes a while to get used to a med. It takes a while to compensate for that med. You got to give things some time to settle out. And if things are not intolerable, try to give it time and be a little bit patient about it as you're making those changes. And I think in many cases, you can slowly start to zero in on what is the best regimen for that individual, even though it will obviously take much longer than you wish it would.
Yeah, ditto. Totally agree. But what I would add is just, and it goes back to that pitch I made earlier about having like a really good log of sort of the med history. You know, I often see, especially in older kids and adolescents as they're approaching adulthood, that, you know, parents will come to see me for the first time, and the list of medications is many more than 4. It's not all antiepileptics, but they might be on 4 AEDs, but then also some meds for sleep and behavior and side effects. You know, and there's like, you know, meds for side effects that are then causing side effects. There's more meds. And it's very difficult, as you know, in that position for you know, for me to decide and to work with the family to figure out how do we clean this up a little bit. But the reality is most likely some of these medications have been on for a long time and new providers are reluctant to make a change, right? Because we don't want to rock the boat if things are not, you know, if anything, you know, things aren't terrible. But I do think it's important to every so often, and I don't know what that so often is, it depends on the child, but I don't know, I'll just say every year or so, just to take a hard look at the medication list and ask, are these all needed still? And I definitely think that's true for kind of the behavioral meds, because sometimes we add a medication on and it's just, we're not sure if it's working or not, so we keep it on. But as Scott said, every medication has the potential for not just side effects, but interactions with other drugs and medications. And the other thing I'm just going to say as a plea or a pitch is that I think we as physicians don't always do a great job about asking about non-prescribed medications and supplements and other treatments. And I think sometimes, you know, parents are like nervous about telling us because they don't want us to judge or to question it. And I would just say, you know, please tell your provider about everything that your child is taking. Because, you know, not because we're going to judge or, you know, question it necessarily at all. It's just that it's helpful for us to know, because some of those supplements can interact with some of the prescribed medications and they count in the list. So I always ask, because I used to not ask as consistently, and then I realized, wow, there are actually a lot of supplements that my patients are taking for sleep or for other things that are important for me to know. And I'm not always opposed to them at all. If it's not hurting and that includes your pocketbook, you know, to be taking something that may not have been studied well or be evidence-based or so, I'm completely supportive of it. I just want to be able to have the dialogue and to have transparency, you know, both ways. And yes, you need a provider that listens to you. You need to be able to feel safe and have a really, really healthy dialogue, because it's a partnership. You know, we all have the same goal, right? We want what's best for your child. So and I hope that's always true for any physician that you come across. But I think that if we can have healthy dialogues about it and we remember that we're on the same page, I think that can actually be very impactful.
Yep. Yeah, I absolutely agree. Yeah, I guess that's a nice part of going last. I don't really have much to add. I was gonna definitely add what Shapali just said, that you know, it is good because you know, we do have kids that are on 4 meds, 5 meds for seizures, and it's good every so often just to sit and look at the list and say, is there something here that's just not adding much, and can we get rid of it? And that's always the best way to kind of chop the list down. And then if you need to add a new one, you've gone from, you know, 4 to 2, and then it's a lot more like palatable to add that other med. And then the only other thing that I would say that I haven't even said is kind of in a kind of an effort to not add too many medicines. What I like to do is try to do like a 2-for-1. So if I have someone with seizures and isn't sleeping well, then something like a clobazam can sometimes help with both. If someone with seizures who's got some mood issues, then something like a lamotrigine can sometimes treat both. If it's seizures plus headache, then maybe a Topamax can kind of treat both. So sometimes medicines, what can be a side effect to someone can be a benefit to someone else. If it's, some syndromes have eating way too much as part of the syndrome. So sometimes a medicine like Topamax, that side effect of appetite loss can be a problem for some kids, but for those kids, it might be a benefit. So just thinking about the other uses of a medicine and the potential side effects, which sometimes may be a benefit. If you can treat 2 things with 1 medicine, that's a great way to keep the list short.
Great, thank you. So this concludes this panel. Are you both going to be at the breakout later for AP Ring 14? Okay, later today when we do breakout, there's a fair amount of questions about 8P and Ring G15Q that are in the app that weren't specifically addressed for the G15Q. But later today when we do our breakouts, the G15Q room, the 8P room, and the Ring 14 room, Dr. Demarest will be available. Maybe I think she'll be there too. And then Dr. Jespe will be in the D15Q room. So we'll be able to address those as well. And additionally, there's some questions about SUDEP and some other surgical interventions. Actually, in 2 sessions, there's going to be, Danny is talking about SUDEP and as part of the technology and devices. And then in the surgical treatments for epilepsy by Monica Jones will address some of the other surgical interventions and some of those ways to go about talking about that with your physician. There's one more question here that I do want to address. It asked, are you able to connect with these physicians? Are you able to connect physician to physician if there is something that needs a consult? With the 15Q Clinical Research Network, that is something that we do. If you ever want your physician to connect with the clinical network that we have going on, they're able to email Zoe, they're able to email me, and we do a direct introduction to the Clinical Research Network. For 8P Ring 14, I'll leave that up to Dr. Demarest, but I'm pretty sure he's willing to consult as it comes up. But I think that that's the best part. Those physician to physician consults are really the best way to go about it. I know that at different times you want to say like, oh, I want to go and see Dr. Demarest, or I want to go and see Dr. Thiebert. But at the end of the day, if you connect them up, you're teaching another neurologist to take care of another patient maybe past you, and spreading that information and spreading that approach is actually one of the beneficial things about these networks. So that is an available thing through all 3 of our organizations. So if there is a need and you want to do that introduction, email whatever organization you're part of, but it's something that we do and we really pride ourselves in spreading that information. So a big thank you to all of our neurologists. Shapali had to go. I know she had a hard stop, but thank you, Dr. Thiebert, Dr. Demarest, and Dr. Wally. And we'll take a little bit of a break and we'll be back in here at 9:35.